Good morning, everyone. Welcome to the EpicEPR orientation event for SMEs, subject matter experts. Um, I will ask you to bear with me. This is my first time doing a live event, but I have a very reliable team backing me up who are going to be directing me to an extent. And we will pass over to a number of different presenters throughout the morning. For the next probably 90 minutes, we'll go through a selection of slides just to orientate you to what the EPR program is going to mean to you and mean to the organisation. Um, we will open to questions probably in about 20 minutes. We just want to give you a little bit of a feel for the programme, and then you can put those questions into the chat. We will try to answer them within the chat, but also take some to the end of it, and we can kind of articulate a bit more of the context around the answers. So moving forward, I'm going to just go into the first slide. I'm just going to see if I'm controlling that or not. Oh, Anna's doing that for me. Perfect. So sorry, the slide's not coming up on my screen properly. Let me just switch to this one. So the main thing around the EPR program is it's not another IT project. It is an organizational transformation, which we have been probably long waiting for many of you from your backgrounds in clinical, operational, or administration. You have suffered probably the frustrations of using multiple formats for managing our information and our data. This is the opportunity now to move forward and standardize our approaches and to just ensure that we're all on the same track with the same outcome. And then that outcome is related directly to our SNEFT objectives and our clinical strategy in keeping people in control of their health, leading that integration of care, developing the centres of excellence in all areas across the trust, and then supporting and developing our staff, in particular in areas of digital literacy, where we really need to work hard on over the next year and a half. You will hear a lot more about the training background to Epic, but also other work going on around how we use our data, how we manage Excel spreadsheets, how we manage Power BI reports, things like that. And then driving technology to enable care. And this is the key. I think the technology that we support from an IT and a digital background enables the organization to use it, but we're only the enabler. You and the rest of the whole of the organization has to pick that up and use those tools to help us get through the next generations of work that we're going to do within SNEFT. I'm just going to quickly run through the timeline. So we'll go to next slide. This is a program that did start about 2.5 years ago, and someone mentioned it yesterday in our orientation event that it takes more time to write the business case and get it through to 14 levels of governance than it does to actually deploy the product. So that just shows you kind of the level of effort we've put into this. It is a huge investment for the trust, and it's an investment over time. But we will see the fruition of that at the go live point, but also through the following years. Having used Epic in the past, the trust, you see the development of these products over years, 4 years, 5 years, 6 years beyond your go live, because we'll never be perfect on that point. We need to get to a point where we want to go live, and then after that, it's really seeing the value in the functionality you have. And as end users get to use the product, you will see opportunities that we may not see as a digital team or an IT team, and you have to then bring those forward. It's again the more detailed phases I will leave for Nathan. Nathan's going to go through them later. He is worried that I'm going to steal all his thunder. Well, I'll try not to do that. And we'll go on to the next slide. So, and again, I'm seeing different things on my screen, but we'll go for that. So within the program, we developed over a period of 3 months earlier this year about our program principles. What will the program mean to you as the end users? What will it mean to our patients and our communities? We've adopted again our time matters philosophy. We need this to achieve our ambition. We have to make time for the EPR. I think if we don't put in the time and the resources over the next 18 months, we are not going to get a product that will be useful for anyone. So the key is that everyone needs to commit to that time. the time matters again, developing the system, making swift, pragmatic decisions. We'll go through a bit more about the decision-making process, but essentially we can't procrastinate over decisions. We will keep them aligned to a lot of our work on the clinical strategy. There's a lot of work going on with transformation and Shane Gordon's team. We will keep as much aligned to all of the programs of work, but the key is the focus has to be on getting EPIC up and running October 2025, and we need all your support to do that. Patients are central. So this is something that I learned very gradually when I started, when I moved to the Middle East. I realized in a new hospital, we were all concentrating on our parts of the puzzle. We were all concentrating on our workflows. But the reality was, it wasn't until the organization kind of got that mantra of realizing, let's put the patient in the center of this. Everything has to be done for the patient. Everything we design, the outcome of that design, you have to put this patient in the center. We are all empathetic to patients, but we also are empathetic to our own workflows, what it means to us. But without the patient in the center of the design, it's not going to benefit them, and that's where this is the true value of the EPR. In saying that, we want to make sure it is a user-centric design at the same time, but that's incorporating you guys to design this. So this is where, as SMEs, you will be part of those decision-making processes. We will take your expertise. You know the workflows, we don't. We will be the first to admit that, but what we will know is the functionality, and we'll be able to merge that and help everyone understand what the best approach is going to be. Yes, the EPIC first. I think this is key. This is a huge investment, and Nick mentioned it yesterday in the orientation event. This is a generational investment. This is not going away. We need to get the foundations in right, and then to support that standardization, it's the best use of resources. But the key is that if there is anything else out there that someone thinks we need to fix this, we need to do this, we have to look at EPIC as being that solution. It may mean that we'll have to standardize some of our processes. We may have to change the way some of us work. We will work together to do that, and then we will promote any standardization that we need with the resources it needs to get there. The functionality around, in the first sense, and it's that future digital need. We'll go a bit more into the functionality as the weeks and months progress, and you will see much more of this within the RDG meetings. So you will get to understand what we can do with it, with the tool. Within these program principles, it's important to keep remembering them. We don't want to stray from them as much as possible. We have to keep everyone, I call them guardrails. We need guardrails for everyone to kind of adhere to and make sure we get to the end point together. I think that's key, and we all work in parallel to get there. Just to introduce you to a bit of the program leadership structure, we'll go on to the next slide. What we really want to kind of get across is this is a clinically led and an operationally led transformation program. So as you can see, we have the first slide indicates that commitment to those clinical information officers. We have a recently appointed clinical chief pharmacy information officer. We have Nathan, who you'll meet later on the program, and then we have our executive leadership and our CIO and Andrea Craven. So there is a huge clinical backing to this. There is a commitment from the trust over the last 2 years to help build a clinical informatics team. Again, you will meet them throughout the program. We will introduce to what that means. But clinical informatics is generally a new concept to the NHS. It's something that I had done previous to coming back to the NHS, but it's having that clinical insight in the design of a product that gives clinical tools and intuitive clinical workflows within the digital tool itself. Going on to the next slide, we have some more of the team and the operational side and the digital team. So that'll come, and I'm just going to skip through on my slides. And as you can see, again, there is a large scope in this program of work. We have a number of areas covered throughout the FBC stage. We've had huge support from our financial colleagues. We have, beyond these teams, we've built, there's a training team that's going to be supported through the faculty of education and through the clinical education team. We have our operational leads in Michael and Lauren, who's recently joined the team. So we have, again, a vast experience and knowledge throughout the program. They've all been, well, the majority have been on their training courses for EPIC now, so they are starting to really see the potential of EPIC, and they'll be able to help translate to everyone what that means to you. The relationship with EPIC, I will hand over to Justin in a second, but I'm just going to we pop this up. Felicity Bloom is our EPR implementation director, who did say this in one of our earlier meetings. They said, we're the personal trainer you'll come to love. Now, having recently taken on a personal trainer, I haven't come to love him just yet, but we are getting there, and I can see that relationship building rapidly. I think this is really important. I think this is a relationship with a supplier who I have worked with before, and try not to show bias, even though at times I may. I have found them to be a supplier beyond any other expectation I've had with any other supplier. I'm not going to big it up too much because Justin might get very embarrassed, but I'll hand over to Justin, who'll kind of go through a little bit about that relationship now and what they've experienced working in other NHS trusts.
Hey everyone, well, I'm over here blushing. Thank you, David. My name is Justin Schaefer. I am the EPIC Outpatient Application Manager working with SNEFT over the next couple of years, and really do appreciate the introduction there. This quote says it best. We will be working with you all as the subject matter experts and the program team throughout the next couple of years, bringing our expertise from over 10 implementations in the UK and implementations in 13 countries around the globe to ultimately walk through the process of design, configuration, testing, training, getting you all to go live, and working with you to really refine and continue to fine tune the system beyond. As I mentioned, the quote says it best. We are your partner. We're your trainer through it all, and we want to work with you through using protocolized best practices to drive the best outcomes. Our goals are the same as yours for this implementation. Ultimately, we might push you at times, get you to those goals, get you to the right outcomes, but we are here to work with you along the way as your personal trainer to meet our shared goals. So I'm going to now pass it back off to Nathan, who is going to take a deeper dive into the timelines for the program.
Good morning, everyone. Thank you very much again for joining us this morning. So my name is Nathan Richards. I'm the head of EPR delivery for SNEFT. You may have clocked on the previous slide of the pictures. I was the bottom right, and Andrew Craven, our program director, likes to point me out as the one with the small head on that slide, so you can remember me like that. So very pleased indeed that David didn't take entirely all of the thunder for this. I was gesturing madly at him not to, so thank you, David. I think in terms of the overall timeline, the first thing that you will spot is that it's a short timeline. So we are sitting here now in June. As the slide shows, we are aiming to go live in October next year. That's really not a long period of time. I'm sure many of you as SMEs in various areas of the organisation have been involved in projects and programmes before that have had a longer timeline and have delivered less than we will with the EPIC programme. I think it's important to acknowledge that and acknowledge that we're doing this very differently. So Anna will talk through a little bit later around the change network, around the rapid decision group structures, which I think effectively enable us to do this differently and to deliver much quicker things that we had before. We also, as David said, there's been a significant investment around this program, around the resources around it. So from a resourcing perspective, we're much better off than we ever have been for any other program of work we've delivered before. So that's what gives us confidence to deliver. Equally, again, it's that personal trainer pushing us on. EPIC have a fantastic reputation for delivering on time and will help support us do the same thing. So firstly, then the pre-work phase. So probably not many of you have been involved in this part. It's touched different parts of the organisation. The pre-work phase is really all about getting ready. So it's about some of the groundwork questionnaires that we've been doing around the organisation. We're basically gathering information to shape the facility structure, which is what EPIC is built on, bringing in all of our resourcing and things to get us ready for the first part. But really, we're now standing at the start of phase 1, which is the configuration and build phase. So this is really important phase where we're making big decisions on the workflows that we will have in EPIC and the ways that we will work. So you can see there we're running from now up until November. One of our favourite stats to tout is that in an EPIC program you can be asked to make up to 15,000 decisions. And that's coming back to what David said at the start of the presentation. That's why it's really important that we make swift and pragmatic decisions to keep on track. That's what the whole RDG structure that we're going to present to you later is around. But that is what you're going to be involved in as an SME. It's about being brought into those groups where relevant to help make those decisions quickly and represent the area that you have expertise in. So we're going to be doing that up until November before we move into phase 2. So phase 2 is around user and system readiness. So there is a whole organizational readiness strand to this program in terms of getting ready for the go live, also helping with all of the testing. We have various different rounds of testing in terms of testing the migrations work, testing the workflows work properly. And again, we want to involve you in that. So previously in other programs or projects, you may have been involved in just one phase of this. You may have even just been involved in just the training and the go live. What we want to do is for our SMEs, for our RDG core members, our chairs, all of our EPIC experts, we want to involve you all of the way. So we expect you to play a role as well in the testing and the training, because it's about validating that what we made the decisions on in the summer works for us and works for SNEFT. So that's what phase 2 is all around. There's also a bit on things like device deployments, checking that we're ready for end user devices, preparing for super user training as well before we end up to phase 3 in training. So I think in terms of training, again, we're looking to do something slightly different. The board is very much signed up to peer-to-peer training. So through historic deployments, what they've found is that being trained by a peer is much more, it has a very, very high success rate for adoption. So we're looking to try and facilitate where we can some of your peers, and that may be some of you on this call helping us to deliver training. We have in the region of 12,000 people to deliver training for in a 3-month period. That's a really aggressive timeline that we have to meet. That's a lot of spacing considerations around that, a lot of people that we have to free up. And again, we've got to look for the whole organisation to support us with that. There are things that, difficult calls that we're going to have to make around things like other responsibilities in the organisation, like training, things like mandatory training, for example, things like annual leave management. We have to have a collective view on how we're going to do that, and again, we'll be looking to you to help be a sounding board to provide that support. But so then we move through the training before the go live event in October. As David said, it's not really about the go live. The go live is the start. We plan to build on this for years and years to come. So we want to deliver transformation through EPIC for the next 10, 15, 20, 30 plus years. So it's all about continuing that momentum afterwards, which is why as SMEs, your role in this is hopefully long term. Yes, you'll be part of the decision structure up to go live, but we want to keep you involved post go live, as we want to keep everyone involved in the decisions past then, to keep the momentum going so we can get that continuous improvement cycle. Which is what Thrive is all about. So you'll see mentions to Thrive. This is all about thriving beyond the go live, making sure that we're continuing to improve things, continuing to adapt things as well. So and continuing to really continue the journey for what we want to achieve with EPIC, ultimately overall. So hopefully that's helped a little bit in a breakdown of the timeline. I know it's an awful lot to take in. I think I'm passing back now to David, who's going to talk a bit about the governance structure and a bit around RDG structures and things, and your involvement in that.
Perfect. Thanks very much, Nathan. So this slide will probably look like any other governance structure slide you may have seen in the trust before. The difference is probably the 60 odd groups that are at the bottom of this slide deck, and then the next layer up. Any program of work of this scale has a certain level of governance, and we've probably been running some of these governance groups through our FVC stage. Some people who may have been involved in that FVC stage may have known it as the EPR steering group and things like that. But this is just now ballooned out to incorporate the whole trust since the FBC and since we've signed a contract at the end of March. The main kind of view on this to look at is top, middle, bottom. The top is going to be where a lot of the strategic decisions will be made. We'll go through some of those decision types in workshops and through the RDG meetings. You'll see what the difference will be. But the strategic decisions will be taken in context of where does the trust want to be, what's part of our current strategy, and will those design decisions have that, where they'll have that impact on those strategic kind of objectives. The next level down is about workflows, and around the advisory councils and with some of the rapid decision groups, we'll be making some key decisions about how workflow operates at an organisation level. So if you think of the generic workflows, things like an admission, a discharge, a transfer of care, they will be areas that we will probably look heavily into the advisory councils for support, and again made up of SMEs who will, some of the SMEs on this call will pass through those advisory councils as much as the rapid decision groups. Then we'll get to the rapid decision groups. This is where the bread and butter, it's, someone describes it as when you build a house, you have the walls, which will be your strategy. You have the doors and windows, which is a bit around your workflow. And then you have the curtains, the lamps, the furniture, which is where the content sits. So as we build out that content, we need your support in designing it to the most appropriate level to meet your needs, but also then to meet the needs of the patients. The rapid decision groups, I'll go into a little more detail about what the makeup of rapid decision groups is later on in the presentation. But the key to remember is, as SMEs, you are the experts in your area, and we need your support to be in the voice in the room, regardless of whether it's strategy, workflow, or it's content. You will have we need you to be present, and it goes back to that core principle of making time for EpicEPR. I think we don't want to have in 18, 20 months, 24 months, 36 months time, anything around, well, I wasn't in the room, I didn't have an opportunity to design this. This is your opportunity, and this is a huge opportunity that will probably never come around again. So to be part of this is really important, and to take the consideration that we really need your help. Around definitions, I'm just going to go to the next slide. We have, as I said, we have the strategy level, we have the advisory, at the design authority, advisory council, those high level role based impact. They're generally role based impact decision making, but there is representation of all roles on each advisory council. So MAC is the medical advisory council, but we have nursing representation on there. We'll have AHP representation on there, vice versa within the nursing and the digital NMAC advisory council. We will have some physician voice at the tables when we need them. We'll bring the SMEs as we need them. We don't want to waste anyone's time, so it will be probably by invite more than as a regular occurrence. But that will again you'll see this more as you start getting involved and you get into these meetings. The rapid decision groups, again, at the top of this, and this is where we need to consider where we want to be in 2 years and 3 years time. As we move into optimization and the kind of business as usual of maintaining a system the size of Epic, we need to continue that shared governance approach. And I think a lot of these rapid decision groups, while we will absolutely need them for the next 18 months, they will morph into that shared governance structure as we go forward. So that's something that will come later. But again, when you're involved now, you're at the foundation level of this build. This is where we get the voices heard. I think I'm going to pass on to Anna, who's going to just discuss a little bit more around the change network and how everyone's going to get involved.
Thanks, David. So as Epic experts, which is what you are, you're also part of our change network. So you're not just providing us with your the information that you know, but you're also going to speak to your colleagues about what you know and also what you've heard and the decisions that have been taken. So our Epic experts are our change agents here in this context, and I'll talk in a minute about how the role of the change, the Epic expert as a change agent will develop over time. But we're asking you to talk to your colleagues as well. We're not asking you to just come, make a decision and leave. We're asking you to be part of the conversation. You'll find out in advance things like what it is you're being asked to do, to discuss. And if you know that there are people who might have an interest in that, we'll be asking you to do that. So providing advice and understanding about local implementation of the change and how the Epic system needs to be organised in order to meet the needs of the services. But you'll be also taking out information and saying, okay, that's going to make a difference to us. How do we need to change our practice? And is there a change to practice locally as a result of the system? So I think one way of looking at this is that there's a sort of a funnel. So how does Epic impact the organisation as much as how does the organisation impact on our configuration of Epic? There will be things that we need to do. simply because we are creating a single clinical way of doing things rather than the multiplicity of different things that we've got across different sites and caused by different systems and ways of working that we currently have, which are inherent to the way that SNIFT has been up to this point. So fundamentally, we will be building a single organisation, as David alluded to earlier on, a single organisational way of doing things. And that may mean that you've got an opportunity to finally do something that you've always wanted to change, but it's been a bit tricky. Or it may mean that you go, actually, I'm going to need to change my practice slightly in order to make this work, and then have a conversation about what that's going to look like. But you're not alone in this. We're not saying, here you go, over to the organisation, crack on, and just deliver change. You're going to be supported by, we'll provide you with a whole load of support from the programme team. So within our programme team, we have our clinical informaticists. As David said, it's a new role. They are clinical team members. They are AHPs, they are pharmacists, they are nurses, they are doctors, they are tend less to be doctors, but they could be. Our clinical informaticists are basically the people who are really adept at translating. Think of them as your translator, translating the technology into clinical practice and translating the clinical practice into the kind of technological, if I can say it right, ways of working. And they will be really incredibly useful, and they will be involved in and supporting your RDG. The clinical application leads, so each part of EPIC is built kind of in a modular way. Most front-end users will never see that. They'll just see the screen that they use. But each different module has a clinical application lead. So each RDG, Repro Decision Group, will have a clinical application lead, and they will be in contact with you soon if they haven't been. Some of our RDGs are still in development, so some people haven't been contacted, and some of our clinical application leads are also still out of the country having their training, and this is really quite intense training, so they will really understand how to get the best out of the systems and how to use the systems to help support you. And we'll talk a little bit more about how that's technically done shortly. We'll also have our project managers, our IT project managers. They'll help us to get some of these big changes and big things done in the way that we know that project managers do so well. And we'll also have our EPIC colleagues. You met Justin just now, and he's working on our outpatients module. I think we've got something in the region of between 30 and 40 different EPIC colleagues who are going to be working with us to develop each of these different parts and on each of the rapid decision groups. So they are extremely experienced, really, really knowledgeable bunch, and hopefully incredibly friendly and really easy to work with. So they are going to be as much a part of the SNF team as we are, and they do already, I think, feel pretty embedded, and they'll continue to do that. They'll really start to understand, and their job is, and their interest is, to understand what it is about your job that you need to have understood. So and then to translate that into, okay, and the system can do this, or this is what we've learnt from the previous installs in other parts of the NHS. This is how we think you should do this, and this is why we think you should do this. They always come with lots of information and support about why we're making the decision, or why this is the suggested way forward, which I think you will find incredibly supportive. And then we also have in our RDGs, we also have our training team. So our training team will be supporting you all the way through. And if you make a change and you say, my goodness, that's going to make a really important change, but it's going to be a really important part of the training, then our training leads will be picking that up. They'll be building the curriculum that we're eventually training people on next summer. So it'll be really important for them to be part of this. So I really hope that you can see that you'll be well supported within your roles in our rapid decision groups, and that information cycles through between you and our colleagues from the programme team. So you are there, bring your knowledge, bring your interest, bring your experience, and they will take that and build that. We're not expecting you to do that yourselves, absolutely not. Your best place is to give us your information and then carry on looking after our patients in the way that you do. And then our programme team will be responsible for taking that information. If there's a need for escalation because a decision can't be taken or anything like that, they'll be taking that to the design authorities. That's not your responsibility to do that. So hopefully, I know some people have been thinking, how can I possibly have the administrative burden of this? How could I have the time? And this is what the programme team are there for. However, what your job is to do is to use your network and talk to the people that you know and the experts that you know that you work with to help them to understand the change that's coming, also to help get their input. You can represent them as well, but you're the person named in the group to help make that decision. So if we know we're going to part A or part B and you say part B is better, then that's the decision that will be taken because you're the person there giving that advice. In addition to the change network, there will also be, as we get further through this, and I'll be looking to recruit these people in sort of summer and into September time, we'll have a group of people who will be our ambassadors for change, our change champions. So people who are less necessarily the specific staff specialists or specific area specialists, but people who are just really keen on the change or can understand why it's going to be helpful, people who are well networked, people who are really keen to help us with messaging, and also so they will work, you know, to help deliver some of our program messaging to make sure that that core messaging is being pushed through from the programme, so everybody has an understanding of major big ticket items and decisions that have been made about how the system will function, but also then help us to understand where there might be rumours brewing or misunderstandings of stuff happening, so that we can pull through that rumour mill, and there'll be a real conduit of communication through change, as well as supporting us to make sure that everybody who needs to know things does know what they need to know. One of the really important things about sort of communication that we have understood and really kind of involvement in this programme is that the groups, this is what we've heard in a lot of our colleagues organisations who have already got EPIC or have recently put EPIC in, is that the areas, the clinical areas where the engagement is highest have the best experience of how this is rolled out. They have the best experience at go live, they have the best experience going forward. So really your involvement and your engagement is hugely key to the successful impact of the go live when we do it, but not just the go live, but the go live and then that optimization phase. It won't be perfect in the 2, 3, 4 weeks immediately after, but in the 2, 3, 4 months and the 2, 3, 4 years after, your work and the work that you do now will make that really important change, and your continued enthusiasm for the project and your continued understanding of the project will be enormous. And that's what we're using the change champions and the change network for, so change agents and change champions. So you'll see more about the EPIC ambassadors soon. So just want to talk a little bit about the evolving role. Oh, sorry, just to be really clear, I forgot this. I had this slide in here, but just to be really clear that the involvement of people is built in, so we don't end up with a situation where we have people saying, oh gosh, this system, if only I'd been involved in it. There should be an opportunity for everybody's voice to be heard. If you tell people that you're the local subject matter expert on something and that they've got an opportunity to talk to you about it, then you can make their voice heard as well. It's really important that you're taking the effort to do that, and you don't have to make specialist effort, but you go to meetings that you'd normally go to and talk to people about what you're doing. But we're baking the involvement in, so we're not in a situation where somebody says, if only someone had involved me in this, it would have looked like X. So yes, sorry, to go back to this, so the timeline of an EPIC expert. So the role will evolve over the period of the development of the system. So right now, we're asking you to be an active member of your rapid decision group. So take decisions, really be keen to go into those meetings and take decisions. We can always revisit them afterwards. What we don't want is a decision to be avoided or a decision to be revisited multiple times. What we really want you to do as well is to help us to articulate the impact. So if we decide this between what part A and B, if we decide B, then what is the impact of that change? Is there an impact, and do we need to do something with that as an organisation? When we've understood that, then we can raise that into the programme and then perhaps do the necessary change. It might be a change to a SOP or a policy or something like that, or just a simple change to practice locally, the way we do things. Instead of pulling that lever, we now need to pull that lever, or whatever it is that you're doing, and also speak to your colleagues. So that's between now and the end of November. Then when we go into the testing phase between December and June, we'd really like your support with system and user testing. That may be less support during that period than you've currently given to your RDGs, but if you could help us with that, just making sure that those things are the things that you're really keen, and make sure that those pull through. And then continue to be an active member of the EPIC expert community and to help us to create content and change, but also the RDGs will continue as well. So continue us to putting some of the sprinkles on the cake, I think is the metaphor that we've been using. We'll come back to that a little bit later. But also we'll be looking at this point to really start planning for the organisational change and for the organisation to be ready to receive the new system. So again, as I mentioned before, the thoughts and understanding of the impact of the system would be really something we want to hear from you at that point. The next phase of training, we'll we're going to give you the option to be super users, to be trained as super users, and that will mean that we ask you to take training earlier. For our doctors, what we've heard and what we're committed to as an organisation, but what we've really heard from our partner organisations as well, is that peer-to-peer training, particularly for doctors, is something that really makes that training have good impact, and it really means that it lands and people attend, and that we get really good engagement with training. So if you are particularly a doctor, but other people, but you think, actually, I really enjoy training people, and you'd like to become one of our trainers, we'd be really willing to hear from you if you're involved and engaged and think this is a good thing and you'd be keen to do that. We'd really like to hear from you as well. It's optional. We'll probably be asking other people as well, but because by this time you'll have a fairly good understanding of the system, you're a key person for us to try to draw on. So we'd really appreciate that. We'll also be promoting personalisation. You'll see as we go through into your rapid decision groups, there's an element, quite a large element of EPIC, which allows you to make really detailed and personal changes to allow your setup, so you can have a set of orders for things like tests that you know that you do regularly, and they're set up for you, and you just go, right, it's a heart attack, I'm going to hit this thing, and off I go. The set's already in there. So a lot of it that's personalized to you. You can change the way that your screen looks, but you can also do things like set up something that will become later a letter template, or something like that. And we really want to promote that personalization, because personalization, the more we do it, the easier our go live will be, and the better we will thrive, and the more quickly we will thrive post go live if we do that earlier on. So we're trying to make sure that we are really clear on how key that important a feature that is of EPIC, and that actually people's training may then need to continue past the go live point to allow them and to support them to do that personalization. We also really want your support and leadership running towards go live, so helping your team to understand, helping the rest of the organisation to understand. So you're now effectively, you were always leaders, but you're now effectively leaders within this programme, and that represents something and it stands for something. So we will be asking you to also wear a pin badge, which we're going to give to people who are EPIC experts, so that people can identify you really easily, and they'll know that you're an EPIC expert, and those will be coming to you in the next few weeks. At Go Live, we'll be asking you to do some more super user floor walking wherever you can. Again, continuing to support and lead with the team and promote this personalisation, but also, just being a useful ear, and also helping us to understand where there might be pockets where we need to send and change things, and make sure that Go Live goes as smoothly for people as it possibly can. And then, as I've mentioned, into our Thrive phase, which is basically the rest of our lives with EPIC, we'd really like your ongoing involvement. We would really like you to help us to support and encourage personalisation, but also, and it's not on this slide, but it ought to be, we will have a shared governance structure going forward. What that means is the governance of this project will not then go back into IT. It doesn't suddenly become an IT project because it's been deployed. It will continue to be a clinically led system, so there will be clinically shared governance between different specialties and different types of role that will continue to go on past go live, and we'd really value your input where you're asked to in that. We'd also like you to continue to work on optimization. There will be elements of EPIC that we don't necessarily put live in the first wave that we're going to put potentially live later. Support with that, and then also helping us to review our success, to understand how well this has gone, where there might be needs to be snagged, or anything else that we need to do to make sure that this continues to be a functioning and really super system for our patients going forward. So I think that moves us now into our introduction to decision making. So I am going to hand over now to David.
Lovely, thanks, Anna. So just before I go through, Anna, you'll see the slide now for the third time, so we won't dwell too much on this, but I do want to just make a point that the Q&A is open. I'm sure you have plenty of questions, so please just get your questions into the Q&A and we can answer them as they come through. The other thing I actually understand, this is the second, maybe third time we've gone through the slide deck now, you still haven't seen a tangible EPIC platform, so don't worry. You will see it very soon. Our IT operations team have been working very closely with Epic over the last 2 months since we signed the contract, and we do now have our own pre-production environment built on our estate, which is a huge milestone in trying to move the program forward. You will have, I'm going to look at my Epic colleague to the right of me, but we will have a play environment up and running at some point, which I would expect that you would all have access to. That gives you the opportunity to play and not break anything. It is what it says on the tin. And also we'll have access for you guys to UserWeb. UserWeb is a wealth of knowledge about Epic, but it can help you to see what other trusts and other in the UK have done, in particular with how they've designed their notes, how they've designed their workflows, their flow sheets. You will hear terminology that you will not understand. Don't worry about that. We will help translate that. It is just what Epic is, and what these EPRs are just, they're different ways of the way we do things, either on paper or within other systems. So we've already moving from and to. We will help with that translation, and through the RDG groups, the CAMs that are there have already used the Lex Lorenzo Careflow Evolve, so they will be able to translate to what it meant in the existing systems. And also you'll have the clinical informatics who can start explaining what it meant to on paper. So that will all come later, but I'm just conscious that we've gone through a lot of this information and you haven't seen the tangible. You will just have that patience with us. So within introductions to decision making, we've mentioned it a few times. The key is that we have to move at pace, and I think this is where this program, the program structure, has come from. It gives us that ability to move forward quickly. I'll go on to the next slide because we've probably gone through this enough, but the next slide shows you a level of the core RDG. So the rapid decision group sitting at the lower end of that decision structure. Essentially, I always want to turn on its head. The decisions will filter down from the rapid decision through the program. It's not that the decisions made at the top and then filter down to the RDGs. The RDGs are the most important part, in my eyes, of this structure. Within the RDG structure, you have two fundamental differences. One is the core decision groups, which these are many of. Don't worry, some probably are missing. It was pointed out yesterday, we missed radiology. There is radiology. There's also a palliative care RDG. So we couldn't squeeze the 60 odd onto 2 slides. These core decision groups will help us with those walls and windows. Where do we put the doors? I was asked if I'd go into a cake baking metaphor that we used yesterday. I think this is where the chocolate cake is made. This is essentially where we've decided we'd want to bake a cake, but what type of cake is it going to be? It is just going to be chocolate. And all of these groups will have to apply to that kind of structure of, this is the type of cake we want. These decisions will be supported by a lot of work we've already done since we signed the contract. Our program team have been working behind the scenes. Some of you may have already been reached out to for information to provide to get our facility structure up, our pre-prod environment up. So we have done a phase 0 kind of list of jobs which will feed into these RDGs and the decisions that they'll have to make in the next phase. You can see probably by the types of groups in here, these are all very much high-level groups who overarch multiple areas or are very specialist in what they deliver, with a lot of touch points outside of those areas. So you can see you have, so the beacon is the name of the module, but the oncology system itself, it reaches across a lot of areas, but there is a lot of guardrails we want to put in place for that at the start before we start building on top of that. Same for safeguarding, the infection control, medical records, and then the areas of anesthesia, surgical area, radiology is there, endoscopy, theatres, etc. So these are the core decisions. These decisions will be made in the first wave of the build period. So the next slide shows you the specialty decision groups. So some of you will be members of the specialty decision groups. These are divided, I would say, neatly, but not necessarily completely, into 2 structures where you see the starter general surgical workflows and the general medical workflows. We know there is crossover. We know that some teams have a foot in both camps. We know that it's not always going to be perfect. That's fine. What we need to make sure is that these groups are all talking to each other. These groups will help to articulate the decoration of the cake, the sprinkles. And each group will have the ability to make their own content decisions. This is where it also leads into your personalization. So that will come later, but Epic has a wealth of tools in there that can help you to personalize a lot of your work and the tools you use. So creating your own note templates is a kind of very large example. Order sets, order management, things like that. There's a lot of areas that you can control that. So these decisions will be made more likely in the wave 3, which is coming towards September. But in advance of that, we still need your help to understand how you're working now and how we're going to structure those decisions that we have to make. So while the core and the specialty RDGs will make decisions at different times, their involvement is all needed from next month, and that's key. So as much as you can think, oh, well, we don't need to make a decision until September, we need your information, we need help. So they all feed into the advisory councils, and there's a couple of rationales. We spoke about the advisory councils helping to manage the workflow at a high level, but there's also escalation routes. We know that we have a merged trust from 2018. We know there are some ways that certain divisions and departments are working differently from their counterparts. This will all come out in those RDGs because we are building one system. So the key is that within the RDG structure, you will build those relationships that may not exist at the moment. You will be working a lot closer with your counterparts. I've experienced this recently when we did the critical care build for MetaVision about 2 years ago. But since we've done that, all nursing is on the same platform, and these tools they use are identical, which means nurses now can work across both sites in critical care without having to learn a different system, a different process. So this will come into play as we go through those discussions in the RDGs, is how do we work on this site? How do we work on that site? What's the best way? And we have to look towards Epic as that ability to pull that together. I'm going to say, did I miss anything on the core? I think that there is color coding associated to the core on the slide previously. A lot of that again leads into what will be managed in core and what will then move also into the specialty areas. Some will move from core into specialty, some core will just be completed and we'll use them for testing at later stages. Into the next slide, we have the building in waves. So I referred to the waves earlier. The waves will be within the build period up to November, 4 waves. Each wave is about 6 weeks long. Within each wave, we will have X amount of decisions. I think Nathan or Anna mentioned the 15,000. I did look at the decision tree yesterday. I think there's now down to 12,500 decisions. So our pre-work is already starting to bring those numbers down. Each wave will have X number of decisions. I could give examples. I did look at one, I think it was patient education, or sorry, clinical education. They'll have about 76 decisions to make in a 12-week period. And that's kind of where we get to in the RDGs. During your RDG, we will have pre-meets with the chairs and co-chairs going through what's coming up at the next agenda. They will, based on the agenda items, they may ask you to help find some information to provide for the decision. So, and again, this is all going to be very fluid, and it'll just be they'll make contact, say, we have to make this decision for next week. Can you help provide some information for background and context? And then we'll go forward and bring that to the RDG meeting, and then that's where the discussion will take place. The waves will move very rapidly. The reason the decisions have to be made quickly is because we have to build quickly. So as decisions are made, they will output into the configuration team and the analysts to help build the system. Justin is going to go into that in a little more detail, and we'll do a bit of a mock meeting just after we get through these next couple of slides. And then the specialty content design, while we say it'll go into waves 3 and 4, the likelihood is it will continue into early 2025. We can still test the fundamental workflows. We will do a lot of testing, but at a content level, you can still kind of tweak for a little period beyond that. But we do want to get the system built and tested appropriately. And the key behind this is the clinical safety. You will probably have all seen headlines over the last number of years about EPRs being deployed and safety events generally. it's because of the processes as much as the system, but we have to ensure that the process is correct for the system and the functionality we're using. So we will ask your involvement in those testing phases, and then help with, we have to write as a clinical safety case that it will associate to the program. So any clinical and operational staff will probably be asked to help to provide some information towards that. The next slide is about design principles. So differing from the program principles are essentially a way we want the program to work. Design principles are the way we want the design to work. The key part of building an EPR of this size is sustainability. If we make the wrong step at the start, it can cause us some concerns or problems later on that may reduce our ability to use the tools to the best of the functionality they have. With Epic, they have a very rigorous research and development department and come up with new tools regularly. Every 3 months, we will be able to get updates and upgrades. Working on an NHS Foundation system, which has been developed with the NHS trusts that have gone before us. So we are in all essence standing on the shoulders of giants that went before. So we have the UCLs, the Addenbrooks, Manchester, Devon. There's many of these. I'm going to say a number now, 11, but I think there's 2 more added recently. But there is a number of trusts who've done this, and the foundation model now exists based on NHS workflows. So with that, we want to make the approach as standard as possible using that NHS Foundation build. And as you use the Foundation build, it means that you can continue to take those upgrades regularly without having to reconfigure anything in the base of the system. So it's key to get that right from the start. If we do have to deviate from that Foundation build, it will be for a very valid reason, and it may be a clinical safety reason or an operational reason, but we have to explore that. All decisions will prioritize the patient's journey through SNFT, and it's not just about the journey through your workflow. So you may work in a very specialist area and the patient comes through your workflow for a brief period of time. The reality is with a system like this, everything connects. So there is, and Nathan alluded to earlier about the modules, there's 26 odd modules within the back end of Epic. We may not be using them all from the outset, but we are using the majority. To connect those together is to connect the patient's journey together. So we need to make sure that anything that's done at a registration point from an administrator or a ward clerk or receptionist, it impacts what the nurse does at her triage, which impacts what the doctor will do at his assessment, which impacts what the discharge will look like. So there is that continuity that has to be maintained. So it's keeping that patient journey at the center of the design. Any design impacting multiple stakeholders has to involve those multiple stakeholders. We have to stop working in silos where we are. We have to reach out to people and talk to our colleagues in all departments, roles, areas, and make sure that we're all on the same page with this, because it does impact everyone's utilization of the system. And that's where you have that user-based design approach. The RDGs will articulate any impact of the design decision. So when we talk about decision making, we just said, and we're kind of contradicting ourselves, we want to take the foundation build as much as possible. Based on that, the decisions will be, do we need to change process? Do we need to change a policy? Do we need to change a guideline? Do we need to communicate to an external entity, an external provider that we work with? There are going to be a lot of decisions that will actually have to be made. Not necessarily, we will have design decisions, yes, but we will also have a huge amount of decisions and development of those processes and policies. We've already spoken to the policy review group. We're not going to create an industry of policy updates. I'm going to guarantee you that. We will use the existing review process, but we just need to keep track of those. Again, Justin will go through Orion and we can show how we're going to document some of these decisions, and we'll see where we can keep it. And the over-engineering. Over-engineering of a product like this is only going to be to our detriment. The optimization will go post go live, so we don't have to overthink everything. We won't be able to replicate absolutely everything. We need to get what we need and what the patient needs for day one. What we want might have to take a back step, and we look at it after we go live in that thrive period and in that optimization period. A lot of that will come back to the personalization tools, and as you start using the system, you will start understanding what those personalization tools can do for you. And it's key that you give that the time as well. We talk about time a lot, and you're all probably thinking, where am I going to find the time? The reality is, if you find the time now, it makes the benefit later. There was a group of their leadership team went to Belfast for go live last week, and Mike Mears came back and said he spoke to a junior doctor 5 days after go live, and he already said, I'm saving time. 5 days after go live, he was saving time on the ward. So that's the type of commitment we need to get that output. Then what will we be going through? End of user. Yeah, so using, we have to use the change network, faculty education. We'll have support all across. There's another area where we will embed some of these design principles into other areas that we're already working on. So medical device integration it's going to be constant. There are certain touch points for the EPR that we'll have to continue to maintain as well. The next slide shows a little bit of the roles around the RDG. So we have at the top of the board, we can see the clinical operational reps. So these are core members, chairs and co-chairs and subject matter experts. The chair and co-chair will be the facilitator of the meeting. We met with them yesterday. We've gone through some of the expectations that they'll have. The core members are the constant. So there again, going back to your core RDGs and your specialty RDGs, you need some level of consistency through the whole program. So people can see a decision that was made in September, the repercussions that may be seen next July, but people need to know where that decision came from. And you as the subject matter experts will drift in. I refer to it a little bit of a revolving door. You're always open to come to the meetings, to all the meetings. That's the first thing. You may not be required to come to all the meetings based on what the agenda will say, but I'd advise that if you can make the meetings, make the meetings. It will give you a much deeper level of context as we go through the EPR. Then to support the RDGs, we have our EPIC specialists, our clinical application managers, our clinical informaticists, and we also have some project managers who will support some of this. The team below will support with the materials and the decisions we have to make. They will apply the context from the system itself and then translate that into what we think the impact will be on the operational or the clinical workflow. Then again, you need to challenge us on that. We will make some assumptions, but you are the experts. So you have to say, well, this is where the decision will impact us. Maybe we need to consider another route. Maybe we need to consider another change. The supporting this is going to be a commitment. There is a commitment that you may not have had in the past, but I think you have to, we said it yesterday, we are constantly changing as a healthcare organization. Regardless, I think we always see change in healthcare. We see new developments, new processes, we see new tools, new guidelines. So this is just an extension of that to that. And then any changes that we do see coming through will all be directed through these RDGs as well. Getting to the next slide, I can now define what a subject matter expert is. So we've alluded to most of it. Will be part of the decision-making process, but not required at every meeting. And again, as I said, while we're talking specifically to RDGs now, some of you will be part of the decision-making process in advisory councils and possibly in the design authorities. So you may be asked to come in with that knowledge. We need your specialist knowledge. You will all have generic knowledge, we know that, but we really need your specialist knowledge for this, because that's what's key. It's trying to get the nuances of what you do against another backdrop of the general knowledge that we already will have attained. We need your support in the change process and to support the program in a positive light. And going back through our optimism, our key kind of messaging, we need to keep that message going at a positive and a very fast momentum. I would say there will be a lot of decisions made, but it's key to get that message through to your teams. It's trying to understand. There may be some instances where you may make a decision based on what your knowledge is, but you might want to confer with other areas and other of your peers. So that's fine, but use that to deliver the message of the EPR and to deliver where we are and what changes we're making. What we don't want to happen is when we go live is all of a sudden people turn around and say, well, why did this change? How did this change? We have to it'll be too much at once. So we need to try and get that momentum. There is scope to change processes before we get to EPR. So before we get to go live, if you think that this process can change now, that's what we need to probably focus on as well. But that's going to come, again, individual departments, individual areas will have to pursue that. And then the testing of the system, and as I said earlier, it's ensuring that clinical safety and the operational safety. It is so important that we don't build a system that is going to put any of our patients at risk or any of our employees at risk. I think having your involvement at that level is very important to us. It will be a rigorous testing process. It lasts 4 to 5 months. So we will be looking at every corner of the system. But there is always a case when we go live where something may not seem right. We need to know that as well. So you're the eyes and ears then at that point as well. As those EPIC experts, you will be able to put into context why we're doing something, how we're doing it. I'm going to pass on to Justin, I think, for the next one, because he's going to just discuss about what the meetings and the RDGs will look like, what the agenda is going to look like, and we'll go through an example or some visuals on what the Orion tool looks like. Thanks, Justin.
Perfect. Thank you so much, David. So as David mentioned, we are using a tool called Orion that is basically a big database of the 12,000 or so decisions that will need to be made and implemented, configured, etc. throughout the install. That's a whole lot of decisions, so we wanted to take a minute to break it down into something that's a little more comprehensible. What does an RDG meeting, a design authority meeting, any type of work group meeting ultimately look like? For you all, the meetings will flow first with a review of previous actions, any follow-ups from the previous meetings that we may have had, any tasks that someone left with and wanted to bring back to present to the group. We'll of course review the design principles each time. We want to base our decisions on foundation system, move rapidly through them, ensure that we are putting your workflows and patient care at the center of everything we do, etc. Next, we'll talk through any relevant background for the decision or group of decisions that we may need to make today. This will include, at some times, an in-system demonstration. At other times, it'll be a summary of what other UK organizations have done up to this point. Then, once we review the background and provide you all with the context you need to make decisions or provide input, we'll discuss. We'll open up the floor to your feedback. Ultimately, this is your program. It is clinically and operationally led, and we want to ensure that you are guiding the program along the right path. At the end, once we're through all of our decisions and discussions that we need to make, including discussions regarding change management. So what are the impacts to policy? How do we communicate this decision out? What do we need to do to prepare our staff for go live? We'll look ahead to the future meeting topics for the upcoming meeting to ensure that you know whether or not you're required for the next one. If the topics are pertinent to you, please do join. Otherwise, if it's a completely different set of discussions that aren't relevant to your role as a SME, then you know ahead of time whether or not you need to join the next meeting. Perfect. So what do meeting actions look like? What are we going to have coming out of a meeting? First, if there are any process changes or policy changes that are going to need to be escalated, included across the organization and more, we will ensure that these reach the correct audiences and put together really an action plan of who is helping to drive this ahead. If there are any changes in education requirements for BAU training, clinical education, medical students, whatever it may be, we'll ensure to identify those as well and work with the appropriate stakeholders. The actions will also include configuring or updating the system if need be, should your decisions that are made ultimately require some configuration updates. At the end of the meeting, we'll ask the chair to confirm any of the actions as the output of decisions, make sure that we're all on the same page about what this decision that we've made, what we've reviewed during a given work group meeting means for the organization and where we're going with it. And ultimately, the program team, will ensure that we're communicating these out on behalf of the chair, whether it is to impacted stakeholders from other work groups, or whether it is kind of from that top-down approach on the change management side that Anna showed earlier. Okay. You've heard a lot about Orion. And I think the question that you all have in your mind is, what does Orion look like? This particular slide displays an Orion building block for the design authorities. The design authorities are really those people that are deciding what type of cake we're making and maybe the shape of it. So is it a 13x9 cake and is it a chocolate cake? These are the high level but critical decisions that will impact what other work groups do moving forward. In this particular example, we're asking you all, or really a design authority, to determine whether or not personal mobile devices should be allowed for Epic's mobile applications, Haiku, our phone application, or Canto, our iPad application. So this high-level decision is an organization-wide policy. Is it a should or should not across SNFT? From there, RDGs will make a decision, such as the one that Anna will show now, where we'll ask a specific RDG a specific question about how Haiku will work for them. So we know that we have Haiku. We know that we're doing bring your own devices because the design authorities have made that decision. They've given us that framework to work within. But from there, it's up to RDGs and you all as subject matter experts on RDGs to determine how we're working within that framework, what we're building within it, what the sprinkles and the icing on the cake are, so to speak. As we mentioned, one of the most important parts of these work group meetings, whether an RDG, a design authority, et cetera, is to determine how a decision is going to impact the organization. In Orion, after our meetings, we will define the change impact on each of our decisions that we make using this. We'll set the change impact, which you see on the left side, to low, medium, high, or critical. We'll use mitigation status to say how far along are we in our policy changes that we need to document, in our training preparedness, and our planned readiness activities. On the right side, you see deviation. Deviation indicates whether or not the decision that was made during a given work group deviates from foundation system, from the UK foundation system, the sets of workflows and recommendations that we've generated based on feedback from all of our UK sites that are live up to this point. And stealing this from the presentation yesterday, Anna's favorite button is no big deal. This means it's a simple change. It's basically what you all are doing today. You're just going to be doing it in a different system. And there's not a significant deviation from our recommendations from previous UK installs. I think I'm going to pass it back off to David for this slide. Thank you all.
Thanks, Justin. So as that's gone forward, as you've listened to Justin around the decision making, we have to be very conscious that perfect is the enemy of good. When we say that, by the time we get to go live, we'd imagine we will have 80% of their functionality up and running safely for our patients. What we don't want to do is try to perfect everything through the decision-making process. It will take years of understanding the system and how it can benefit you and using the system before you realize, actually, we can change this way, we can change that way. So with that in mind, generally what you look at is post go live. While we talk about optimization, there is a period of time where we will try not to make change and we will deliver a lot of the post live thrive through personalization and through education. We need to use the system the way it's been built and designed, so it may still need that links to process changing. So we don't want to, during the next 18 months, we can't get bogged down. I think that's the key. A decision made on time is better than a perfect decision. So make the decision. We will deal with the consequences as we have to. We will then work out a plan to mitigate in the event of mitigation, but the reality is we will just have to make some decisions very, very quickly. We need to use the escalation process if you can't make decisions. So please don't sit on decisions thinking that we're going to get back to it. We won't. We need to just be aware. So please escalate to your chairs and co-chairs, to your CAMs, to your clinical informaticists, whoever your links are to the program. Make sure they're aware that there is a problem or there's something that we can't resolve. But we will not be looking for that kind of the perfect solution. Going into the next slide, I think we're going to etiquette, and excuse me because I can see part of the screen, but the main thing is that yes, Teams access, we will send out, I think we have a link, and I'm looking for Anna to nod about Teams kind of facilitation and working on Teams meetings. So we will have some information to share with you. Cameras on. Now I've done it myself. I'll go camera on and then I'm having my lunch because I'm trying to get through a meeting and multitasking. That's fine. We understand that people will have time pressures, and if you want to have your lunch, turn your camera on. Please be present in the meeting. I think this is key. The camera on is that being present. Attend all meetings that you're required to and read any of the pre-meeting information. There will be a lot of information. There will be a lot of things coming to you that you may not understand or you will not understand. Terminology is different. Use your informaticists, use your CAMs to understand what you're reading, because the decision you make, you need to know what you're making that decision based on. Ensure your voice is heard, if not overtly. We want to make sure that every voice is heard. There is over 700 individuals involved in the RDG meetings. Of that, there is over 1,000 seats. I think it's 1,200. I think we mentioned yesterday. So there's 12,000 voices essentially. Some people will have a voice for or a different hat for a different meeting. And I did notice in the chat someone has 2 RDGs. That's one of those instances where your expertise is required across two areas. If you feel your voice is not being heard, again, reach out to the program team. We will ensure that you are heard, but also please be considerate of everyone in the group. So ask if someone hasn't got a comment or hasn't got it, we need to just make sure they're included in that conversation and be inclusive and offer everyone's opinions to the decisions you're making. What we don't want to do is end up not having a voice heard and then coming and finding when we go live we've missed something or someone's going to struggle. Be optimistic. Your decisions will improve patient care, because that is the focus. And this, we talked about this patient-centric approach. It will improve patient care. I know it will. I've seen this work. We wouldn't be doing this if it didn't. It will also improve your ability to care for patients. So be optimistic about the decisions you're making. Be courageous in some of those decision making. Just go for it. We are not here to, what we're not doing with Epic is reinventing the same wheel. This is a whole new design. This is a whole new system. This will have a level of functionality you will have not probably seen in single systems across the trust. I would say you will see some levels of functionality that we would see as a collaboration of some systems you may already use, but the reality is this will all be in one place, single source of truth, single system to use. So just be courageous in making those decisions. If you think there's something that's not working, I always say this is like that blank slate. If you think a process works, but probably could be better, now's the time. If you think a process has never worked, but you just tolerate that, this is the time to change it. And then be appreciative and kind to everyone in the group. This is a big step up for a lot of people. A lot of you may not have ever been in these kind of meetings, in these kind of programs, in these types of meetings. So just understand that everyone has a voice, everyone needs to be heard, and just keep, there is a level of well-being across this program that we are fully aware of. Change is a big thing for some people. There will be anxieties. We want to hear those anxieties, but at the same time, you need to be kind to everyone, be appreciative to everyone, and then keep that optimism. The next slide, I'm trying to think, is getting in touch. Yes, so if you need to get in touch, you will through the RDGs, you will have a connection. The EPR Engage email is there as a generic email box. It has been manned by a number of the program team. We're monitoring it. At times of busyness, we may not get back to you as quickly as you would expect, but please feel free to reach out through your RDG links, your analysts, your clinical application managers, through your clinical informaticists, and through the project managers. They're all there to take your questions. If they can't answer a question, they will know where to go for that question. And there are no stupid questions, and there is no, we want to hear everyone's questions, no matter what concerns you have, please raise them. We're open to everything. I did want to go through, I think we have time, are we on Q&A now? Yeah. So I know some of the team have been monitoring the questions coming through. I'm just going to, I did respond to one on the Paris question. And I suppose this is just to give a little more context for everyone around the scope of the programme. The scope of the programme is for all acute sites, so Ipswich and Colchester, and community facilities which have inpatient or outpatient services. So that's the initial scope. The community services outside of midwives will be in a phase after. We will look into that. There is other tools within EPIC that we will investigate to see if they will work for community services, but they're not currently in scope. We will still benefit from EPIC if you work in the community services. You will see the EPIC chart, you will still have access, you're an SNEFT employee, and also with our providers in mental health or in social care, we will still be able to give access to seeing this single source of truth. So they will be able to, I'm giving an example, our tissue viability nurses working in the community services will still be able to see the discharge information, the wound care they had at an inpatient level. They will see the prescriptions that are associated. So the people will have access to EPIC and everyone will benefit from EPIC. But which systems will remain and which systems will disappear is very much at the moment acute versus acute and outpatients and acute inpatient services. I don't know if anyone else had any other questions lined up. Nate, I'm looking for hands up in our team if anyone else saw some questions, because I haven't had a chance to run through them.
David, maybe I'll read them out and then I can say the answer that we've given, if we've given one, and you can give us a nod or if you want to expand on it. Is that okay?
Perfect. Yeah.
Brilliant. So someone's saying, asking us about the dates of the meetings, whether they could be shared, because we don't necessarily know all the dates now that people have been invited to attend. I've said that actually our clinical analysts are still working with some of our RDG chairs. As I said, one of our RDGs was only stood up last week, and most RDGs will be 1 hour per fortnight for the majority of the core members. SMEs will need to probably go to fewer of those. As soon as they're set up, we will know for the kind of period ahead how often that will be and what the frequency of those meetings will be. We will aim to provide as much notice as possible. We do understand that there are some things that we can't, 6 weeks notice for anything that might require someone to move a clinic. 12 to 16 weeks notice, we will try as much as we possibly can. Likewise with the training next year, to provide as much notice as we possibly can. It may be tighter in the next few weeks, but hopefully from sort of that point onwards, we'll be able to be quite clear into the future how far those are going to be. I'm not quite sure whether how much we will be able to notice we'll be able to give to an SME to stand down or whether they're stood up for a meeting. David, you might have a bit more insight into that.
Yeah, I think based on, and again, the way Ryan will work based on preceding decisions that will dictate how much information we need from SMEs. So the reality is going to be, we would like to give as much notice as possible. Within EPIC and the EPIC program have introduced us to a new term called the 5-4-3. So we have 5 days, 4 weeks, 3 months. They will kind of be the structure of how we disseminate information from within the program. And I like to think that may be the way we'll have to do it within the RDGs. I think if we can give 4 weeks notice, we would absolutely love to. That would be the ideal, but there may be cases where we'll only be able to give a week's notice or 2 weeks notice, but I think the majority should be with a few weeks notice. There is the case that within the RDGs, you may have spin-off meetings because we don't have the right people in the room, or we have a topic that may need bigger discussion. We don't, again, want to bog down the RDGs with a big discussion, so we could preempt some of those through Orion, but that'll all come out through as we get the RDGs up and running. We'll see this kind of momentum running, and then the spin-offs will just start happening naturally.
Great, thank you. Next person asked if the slides would be shared. Yes, we'll be sharing those with you following this meeting, probably this afternoon or tomorrow morning. The The next question is one that Damien has responded to. So it says, given the importance and time pressure to set up and peer training, etc., setting EPR, is this to be reflected in job planning and PA support? Damien said, no, there's no funding from the programme for PA activity. This may be something that you wish to discuss with your divisional managers if you feel it goes above and beyond SPA allocation. There's been quite a lot of discussion about this, particularly with our divisional management teams and the executive team over the last few weeks. David, are you happy to expand a little bit more on that?
Yeah, yes, I suppose that the key for this will be that we do have a level of clinical coverage within the EPR program team. So they're going to be the points of contact to help a lot with the peer support. And Damien, I don't know if you want to talk to the FY2s, FY3s, but the reality will be we are already talking to Pete Bishop and Marie Alexander with Faculty of Education and how we're going to approach this, because it has to be a collective approach to how we manage everyone's time. I think it's key. We still have a certain level of, we have to maintain education in other areas, but is there an ability to envelope the EPIC training into existing training? So I've already had discussions with the likes of the Sim Centre, Melissa Parnell, where we're going to maybe try and get an EPIC play environment adopted into that process where we can. So all of a sudden we're starting to get that through, but it's a bit of drip feeding, and it's also a bit of where we're going to get the time from. I don't know if Damien, you want to add any more around the physician time.
Yeah, I think it's going to be complex. We've identified online. So yes, it's going to be complex. Everyone is busy, but the evidence, as we've outlined, is that peer-to-peer teaching certainly works best. We've just appointed some digital fellows who are F3 posts who will be working half-time in digital. And we're also bringing in some other junior doctors. So we're hoping that we'll get a pool of people who we can create time to create some peer-to-peer training. But we are obviously asking for other people within the programme, including members of the RDGs if they wish. And obviously we'd love people to be enthusiastic and volunteer to be peer-to-peer trainers. But we appreciate everyone's busy, and it is going to be something that we're going to have to look at as we go through the programme and juggle people's time. And I think what divisions have to appreciate is that there is significant benefit for the running of their department and not losing activity by having people adequately trained. And it's probably worth putting time and effort into that individual members to make that goal happen as we go live. So this will be further discussions as we go forward with the programme. But if you wish to volunteer, we'd really appreciate that.
Yeah, thank you. And
just,
I know that
just to add, sorry. I'll just jump in. Just to add, we've already had interest with. We have, in particular in the doctor in medicine and surgery, we have employees who have come from EPIC sites. So there is an intrinsic knowledge in some areas, and we'd hope to tap that up because they will have that ability to articulate the change. But also we have had come forward some physicians who had PAs dedicated to change within their department or to digital enablement. So that time will be used as well. So if you have that time identified within departments and divisions, now's the time to probably come forward with that and then see how we can adopt that into the process.
Thanks. And Nathan just wanted to mention something on personalisation as well.
Yeah, absolutely. Thank you, Anna. So I think it was in Justin's slides and it was in David's slides. We've mentioned it a couple of times as well, but really just to zero in on this. So personalisation in EPIC is really, really important. It makes a huge difference to your actual own experience of using EPIC. So through the build stages at the start, we've spoken about how we're going to bring teams together and yourselves as SMEs into the right room to make the right decisions for workflow related decisions on basically how we work with EPIC. And after that, we'll go on to content related decisions, which is a bit more specific to the specialty groups that you saw. But our programme board has set a target for us to be one of the highest rated trusts for personalisation. And that is on the basis that the experience is so much different and so much better for you if you are. So yes, we're going to get to the point where we're doing training. We're going to be going to peer-to-peer training where possible, but on an individual basis as well, we're going to be asking for your support in really plugging and encouraging personalisation, because it will make a big difference to each individual using EPIC on day one. So we really want to highlight that as something we're very keen to do. And similarly, with the peer-to-peer training support, we'll be looking for support from every one of our EPIC experts in helping to get people personalised in the way they work with EPIC. So just wanted to highlight that. Thank you, Anna.
Thanks, Nathan. I'll gloss over the next one. Someone's asking a question which I'm in the middle of responding to by email. How does the EPIC ambassadors fit for services that cross specialties of the ESNEFT EPIC experts are for services that cross specialties and divisions such as cancer and CNSs or wellbeing services, so they're aligned and not purely specialty designed? I have said, and David, you'll probably want to adjust what I've said here, but I've said many of the cross-functional elements will be handled at the design authority or the advisory group level. Decisions that will impact on other decision groups will be flagged within the decision-making system within Orion. So if someone's made a decision here that impacts the decision that you need to take in your RDG, there is a facility within Orion to allow you to see that. David, is there anything else you'd like to say about that cross-functional element?
No, I think we have, and this is probably where the project managers will help. They will have a bit more oversight across multiple modules. And I suppose it goes back to the ethos of the program, where we're building a very large team, but there is a very close relationship with each module team. We will have meetings, so these discussions will probably filter through the program and then filter back up to the RDGs when we know where the decisions are impacting. The other thing is within Orion, we will know where a decision impacts multiple modules or multiple RDGs. So we'll be flagged in the Orion square to say this is going to the orders team and the ClinDoc team or on the Radiant team, whoever it's going to be. So we will have that visibility. But again, I suppose it's up to you as ambassadors. It's up to you just to pick up the phone or have a Teams meeting, have your regular divisional or department meetings, and have that discussion and see, is there anything we're missing? Is there a repercussion on, in particular, and I'm going to say concentrate on your ancillary services, who support you in doing your job, pharmacy, radiology, labs. They'll be areas that are truly cross-functional and are truly kind of, they fill a lot of gaps and a lot of workflows. So you need to be considerate of those areas. But I think it is going to be a bit of a collection of everything.
Great, thank you. The next question is, could we confirm which current systems will be replaced by EPIC and which will be unaffected, please? Damien has had an excellent go at working on this. So he said the goal is to bring as many current systems as into EPIC as possible, as long as we can replicate that system functionality within EPIC. Lorenzo, Careflow, ICE, Metavision, Chemo Care, ARIA Chemo are just some of the major examples. If you want a full current list of scope, please contact us. We will do that. David, is there any other area where you think it's worth mentioning?
Yeah, I suppose there is a lot of systems. I mean, Chris will be into Radiant, into EPIC. The other thing to consider is, I suppose, is what reporting structures are you using to currently do some of your jobs? So we know we have a lot of in-house software developed platforms. So Watchpoint, Sentinel, those systems will be sunsetted. But it's also, how do you use reports, Red Day trackers, ED track board, things like that. They will all be involved into the EPR. So there is I'll go back to my numbers, and Nathan will kind of, a number we used a lot during the FEC. We'd have about 140 to 160 systems or platforms or products that we use to do our work. I'm going to look at Nathan and see if he's going to say anything different. I think around 60 to 70 on day one would be probably an approximate number. So it is quite an extensive list. And some systems, while they may disappear from your workflow, they may maintain in other workflows. So just be aware of things like ICE, where we have a very high usage in community services. There is still the grey area between acute and community that we have to explore a little bit. So there is areas that some systems might disappear from your workflow, but may not disappear from the organization. So that's just to keep that in mind. But it is quite an extensive list, so we can try and formalize a list and send it out. I think Nathan might want to pick up something.
Yeah, I think also just in terms of the departmental systems and other systems that we have, and I know Damien's articulated the answer there, but going forward with what we spoke about in the slides about the EPIC first approach as well, I think anything moving forward that it is discussed about not doing not doing an Epic because there's maybe a really specific specialist system out there. We have to weigh off that against the disbenefit of not having that in a single place. So a huge driver for this program of what people wanted was having information in a single place for our staff and for our patients as well. So we have to bear that in mind. And sometimes it may be that some of the functionality that we have to change and build in Epic doesn't exactly mirror things that are in your current departmental systems, but that's for the greater good. And what we need to do for all of that is take a step back and actually say, what's actually the impact of not having this information and not having this workflow in Epic, because we're doing so much integrated in Epic with things like secure chat and handover of patients and things. We have to bear that in mind. So I think it's one that in the future, when we come to future junctures, Epic first has to be the organisation's mantra, and that's what the board have signed up to, and that's what the divisional leaders in the build up of our business case stages as well have signed up to. So thank you.
Thank you, Nathan. The next question is, do we send a deputy if we're on annual leave or a non-working day? The answer is potentially, if you can discuss that with the chair. Please do not send anyone that no one is expecting to attend. It's very important that the people who are in attendance at these meetings are known to the chair and their specialism is known to the chair, and so that they are able to take the right decisions. I think it's possible if you're an SME, your subject matter knowledge is such that you may well be the only person who's capable of answering the question, and therefore we may delay the conversation until you can be available. So I think there isn't a cut and dried response, apart from please do not send someone who nobody in the RDG is expecting to attend. So it's not simply okay to send another paediatric nurse or another radiographer into a meeting without anybody knowing and understanding why they're there and what the purpose is, and that they are capable and able and willing and committed to making decisions when they're there on your behalf. So I think that's probably the answer to that. I'll move on to the next question, which is, can you be in 2 RDGs? We've mentioned that. Yes, some people are in multiple. In fact, I think the greatest number I've seen so far is 6 for some lucky fellas who are particularly specialist in their knowledge in particularly tricky areas, or they might be a core member of an RDG, a chair of another RDG, and a specialist subject matter expert in another RDG. I think that is probably, that person deserves some kind of I don't know, lanyard or something to say how many they're in, or something ridiculous like that. But yes, it's possible, and the coordination of those meetings will be important as well. So we'll have to have those conversations with the various different chairs to articulate how those meetings, to make sure there's no clash and that you're able to respond to the ask of you. The next question was, will it replace Paris? Which is not actually a system I've ever heard of. Every day I find a new system that our colleagues use that I've never heard of. I feel like there's some kind of big bingo sheet in the sky where one day we'll know what they all are. But David, you've answered this. Would you like to just articulate that for us again?
Yeah. Sure. So I've said it through the thread, but with Epic, there's a tool called Epic CareLink, which will help our community services and our mental health care providers to have that visibility. That's something we'll have to work closely with. In particular, so the areas are the hospital care services. This will be a tool that will help. What we're not doing is replacing the mental health service systems or the community service systems. What you may see is some services who are, and we have found this over the last year, kind of looking through when we were doing the business case and the benefits, some services are straddling outpatient and community service. That there's a decision at that point where we'll have to see, well, where are they sitting, and then we'll have to probably align what's the best tool for them. Our midwives in the community will be using Epic because they'll have that Epic Stork functionality, and that's probably the one tool that is absolutely in community services as much as outpatient, inpatient. But the others will be kind of questioning as we go forward. I don't think we have much more. I suppose the key is the integration. It came up a lot yesterday in the questions as well around how do we see information. This is the key. We have to leverage the HIE. So at the moment, if anyone is using it, I think Andre gave the number, I think we have 42,000 patient queries from how many staff? A couple of thousand of our staff in the last month. 8,000 staff in the last month. So we are very active users of HIE, Health Information Exchange. That comes from information sent from Adam Brooks to West Suffolk, and then is then pushed out through Evolve. We will still maintain that, and what we would hope to do is build on what Adam Brooks have done with their Epic system into that HIE space. So we can share information. Then there's the shared care record, which is already existing. So there is lots of ways to share information with our other providers in the area of social care, mental health, and they will all be explored. So I think that's key. But a lot of this will come out of RDG discussions when we find that there is threads and endpoints that we may not be aware of right now.
And it's probably worth saying as well that there is an RDG dedicated to external communication of exactly that sort, and it's got representatives from our GP system, also our I think St Helena Hospice. There's a colleague from St Helena Hospice on there, and various other organisations that we speak to regularly, and particularly those with whom we share patients. So that will be looking at those, and also the way in which we communicate with those colleagues through the system and out of the system. There's a further question which I think you've probably answered actually just now about with the community using System 1. Is there a proposed time frame before they'll be able to move to Epic? Otherwise, a significant proportion of activity will still remain on a separate clinical system, same issues as now. I think Damien has answered this. He says at the moment there's no discrete timeline for bringing phase 2, e.g. bringing community services into Epic. This will be decided by the Trust Programme Board. However, community users will have access to see information in Epic. David, do you have anything to add to Damien's answer there?
I think that's it, and then it was answered in the previous. If there's any follow-up, please just ping us a message through Teams or through email. We can answer it. Fantastic,
thank you. Right, so then there was a comment here rather than a question, but it says completely agree about setting the foundations for an effective RDG team. I'm so sorry, my mouth is not functioning as fast as my brain today. Utilising the theory around teamwork, around creating a psychologically safe environment, and psychological safety needs to be embedded within each group. And I think it's just important to say that we did have quite a long session with our chairs and co-chairs of our RDGs yesterday about actually facilitating a functioning RDG meeting and what a good meeting looks like and what a less good meeting looks like, which is partly why we're asking our chairs to take a look at people's physical body language as much as they can, and because they're going to be virtual, that's why we're asking our colleagues to all have their screens on. We understand why you turn them off, but to have them on as far as possible. It's difficult enough to understand body language through a screen at the best of times, but if you're not able to be seen, that's even harder. And quite often, if you disappear from the screen, that might be read as some there's some kind of problem, or you're in fact not happy with what's going on. So I hope that is to some extent reassuring. I think also it's beholden on everybody to make sure that there's an environment that they feel is psychologically safe. And if you feel that the discussions that are taking place aren't, please raise that gently with the chairs and probably the application analyst that's going to be working with you, because they're responsible for making sure that the meetings are running very well, and that everybody is comfortable and feels able to talk. What we wouldn't want is somebody to feel like they don't have the ability to have their voice heard, because something will be baked in that's incorrect. That's quite likely. Next question, will RDG members and chairs have access to Orion? And I'm glad, thank you Damien for answering this, because I didn't know the answer. Chairs and co-chairs will have access, but this is likely to be in mid-July. I know that our analysts will be getting their training week after next. So Orion is something we haven't had access to yet. So as you see, we're still very much in the early stages of this. Quite a lot of it is stuff that we're still eking out. The next question, we haven't even got to answering these yet. So David, these are fresh. Enjoy this. As a subject matter expert, are we told who our relevant RDG chairs are? Actually, I'll take that one. So the answer is you can do, yes. After this meeting, we're going to be sending out to the whole community the link to the spreadsheet, which details who's in each of the RDGs. You can see who your other members are, who your chairs are, who your application analysts are, who your Epic colleagues are. You can just filter through your name, and then or you can filter through the name of the rapid decision group. Some of the names of the rapid decision groups, they should all be fairly self-explanatory. They are fairly Ronseal, but some of them might be called something like Beacon, which is the module for cancer services. So it should be fairly. But if you filter through your name first, then you'll be able to see which rapid decision groups you're a member of and who else is on them as well. So we'll send that link out to everybody shortly. Could be today, could be tomorrow, shortly. It sort of depends on me, and I apologise for that. I will be doing it as soon as I can.
Just to add,
David,
sorry,
yes.
Anna, on,
Yeah,
around the SMEs, SMEs will be subject to change, as will probably other members of the RDGs. We know there is other commitments and there's changes in people's work, kind of job planning and their general duties and remits. So it won't be a static thing, but the reality is we have to have the title in those meetings. So where we have titles associated to your names, it's hoping to get the closest person. We generally have more than one person in the trust in most titles. I know we are probably finding a couple that may be independent and on their own, but we do have that backup. So it's trying to just make sure that we will be a fluid list of people and membership of that group. You may see different people as you attend with a 6-week difference. So just be aware of that.
Yeah, I think this will evolve over time, won't it? And I think as the RDGs get going, the decisions and things will develop. The next question is, we usually have to give 6 weeks notice to cancel clinic activity. How will this work with meetings that we may need to attend? I think, as we said before, should be able to give everybody as much notice as possible, as soon as possible. Some RDG invitations have already gone out and you should be receiving them fairly shortly. If, when we send you the link, you haven't got had contact, then you'll be able to contact your clinical application analyst, who will be sending that for you. There is a chance that your analyst is still out on training, so there are a few people still on training for the next week or so, but in the next 2 weeks you should get that. Otherwise, someone will be in contact with you. So you should have the schedule. If you are in a situation where someone's asking you to come to a meeting next week, then I think that is worth a conversation with the with the analyst and see whether or not you can be pulled out, or whether or not that's not possible. We completely understand that our patients need to take priority over this, and if you can't attend a meeting, as many people couldn't attend yesterday's face-to-face session and haven't been able to attend this meeting for exactly those reasons, we will attempt to catch you up wherever we possibly can, so that's not a problem. But once the meeting schedule is set up, hopefully going forward that won't be as much of a problem. If it does continue to be a problem, then you need to raise that with your chair, because that's something about the scheduling of the meeting that's not working well. Next question, which I think might be the last question. Oh no, there's another one coming. At present, there are no immediate plans to have EPIC system to replace Paris for mental health, but EPIC mental health services, both community and acute inpatient, will have access to EPIC. David.
So, yes, I want to say at a very generic level, how this is going to look, we still have to. So just so you were, EPUT as part of MSC are on their own EPR journey. So more to follow, I think, is we need to see where their journey is taking them before we assess how we're going to use the tools that we both have. I would suggest, regardless of what MSC's decision is, yes, we can give them access to an EpicEPR link, and I'm looking to see if any. I'm not getting nods from Justin and Megan, but EpicEPR link would essentially be that tool that people can look at whatever information we need to front to those teams. Yeah, I think I've got nods from our Epic colleagues.
Fabulous. Thank you. Right. Okay. And I think the last question then, there's nothing else has come through that I can see. Who do we contact if we think we need to change RDGs, as unsure if you're in the most relevant groups to be effective? David.
Yeah, I can take that. There's a level of this where you probably have to trust the process for a little while. We are all learning and we're all on the same journey together. If we have your name in that RDG, it's because Epic have given us definitions of the decisions that have to be made within the RDG. Some of the naming conventions might not make sense now, but when you start seeing the way Epic is built at a modular level, there's decisions that will be made at a certain modular team that will impact, again, going back to the core versus the specialty groups, there is decisions that will have to be made. I think you have to bear with it unless you absolutely are in the wrong, and you can let us know. But I think we've worked quite hard to try and get everyone aligned. Again, it's not a perfect science. It will change, and we're happy to have those discussions. If you think you're in the wrong RDG, have a chat with the clinical informaticist or with the clinical application manager within that RDG. So you should have received an email from one of those people, or possibly the the analyst working under the clinical application manager. So just have a conversation with them, and if you really feel you're in the wrong space, we'll have a look at it. But I think I would definitely say by September we will be reviewing a lot of the program and making sure we do have the right people in the right groups. And because we will know at that stage if there's decisions being delayed because we didn't have the right people in the right place. So I think just bear with it and trust the process for a little while. We've all had to trust the EPIC process since our contract signing, and it's worked so far. So I still trust the process. I'm just going to say, is there any other questions? If there's no other questions, I think we can wrap up, and I'd like to thank you all for your time. And I know, again, the commitment to time is key to this program, and we really do appreciate it. And with that commitment will come a very fruitful product in 18 months' time. So, and it will be to the benefit of the trust, our patients, and our employees. So, yeah, with that, I'll sign off. Thank you very much for your time.